All right. Hey guys, welcome back to therapeutic exercise, right? We just got done with our first 120 virtual lab. I think it went well. Um, it's going to be a little bit different for 140. I plan on using a little bit more kind of case scenarios, especially kind of at the ends of each lab, so that way we can be more dynamic with our activities. We're going to try and partner up tomorrow morning or whenever we do lab. We're going to see how it goes. Don't get too worried about that now. Just like the pelvic lecture for 120, we're going to talk about the differences and the changes and how we're going to move forward to when we have our lab session. So this is just lecture, just talking about the elbow, wrist, and hand. We're going to combine it all. It's 33 slides. And a lot of it is going to, if you remember way back when we did our shoulder lecture, a lot of it is going to be the same as that. So we're going to start talking about different pathologies. For example, when we talk about the elbow, we're going to start with kind of pathologies that end in hypomobility, right? So talking about RA, JRA, degenerative joint disease. I'll get on a tangent about that. And then we'll move into from those acute phases into the more progressed areas. And that's pretty much what we're looking at kind of for the rest of this class, really, is understanding how to progress. So you've already heard this soapbox of you're not going to have your total knee patient doing straight leg raises at 8 weeks if they have a strong quadriceps contraction. You're just not going to do that. That's not skilled care. And that's how I've set up the rest of these classes or these lectures, these topics, going from peripheral joint to peripheral joint, talking about that joint in a acute state, what we're going to do, and how we're going to progress that. Okay. Now, there's no real timeline to use as far as when do you progress. It's usually going to be as the patient tolerates. So your 65-year-old with multiple comorbidities, including diabetes and hyperlipidemia and all these other things, they're going to heal at a slower rate. So we have to progress them at a slower rate. Your 16-year-old active, healthy male, female, they're going to progress at a faster rate. They're going to heal at a faster rate. So we can do those more accelerated kind of programs with that population. Now, last year, we had a couple of students who were all about protocols. Well, there's a protocol for that. Well, there's a protocol for that. Well, there's a protocol for that. The issue with the protocol is that the protocol is a very blanket statement. And yes, it's good to get started on a protocol, and there's a time and place for protocols, but that's not the end-all, be-all, and you have to understand when you're going to progress somebody without a protocol, because there's not going to be a protocol for everything. So understanding how to progress somebody, what their patient tolerance is kind of what we're going to kind of cover tomorrow in lab. But for right now, let's start with our elbow, wrist, and hand. Let's see if we can get this to go operational. There we go. All right. So brief overview, just like we did with the shoulder, brief overview of the elbow. Really, it's 4 joints used during elbow and forearm function, right? You have your humeral ulnar, humeral radial, proximal radial ulnar, and distal radial ulnar. Those 4 joints are going to allow those different functions: elbow flexion, extension, forearm supination, and pronation. Okay, so those four joints are all going to work in unison and be able to allow those motions. Okay, the distal humerus is convex and articulates with the proximal ulna, that's concave, and the proximal radius, which is also concave. So if you remember, we're going to talk about this in. Are we there yet? No, we've already talked about it in 120. Okay, so that should all be a review. Medial and lateral stability provided by the medial and lateral collateral ligaments. Remember that the medial collateral ligament is involved with Little League elbow and Tommy John surgery, where they go in and they have to replace that because of the years of just repeated valgus stress on the elbow, results in an overuse and probably a tearing of that medial collateral ligament. In flexion, there's a varus angulation and in extension there's a valgus angulation, and that's just based on the bony structure, right? So if I'm in Haley, we'll see this during lecture or lab. I'm gonna call you out. But during extension, there's a valgus moment, and then if we go into flexion, there's going to be a varus moment. So it's going to be in a different direction. Okay? During flexion and extension, the slide of the ulna and radius heads are in the same direction because you have a concave structure moving on a convex structure. And during pronation and supination, the glide and roll are opposites because now you have a convex structure moving on a concave structure with the radius moving on the ulna. Let's see. Yep, and the radial ulnar joint, and then during pronation and supination, the glide and roll in the same direction in the distal radial ulnar joint because those joint structures do switch. If you need to do a review, go ahead and do a review. We can ask questions just like in 120. Please, if you have any questions, write them down and ask us in lab, and we will clarify as much as we can. Okay. Actions and muscles. So we have lots of muscles acting around this area, as you remember in 120. So elbow flexion, we have three main muscles. Your brachialis, which is the basement. Okay, you do your biceps brachii. That is kind of that superficial. That's your Popeye muscle. Also does supination, and then your brachioradialis. They're laterally, kind of with doing elbow flexion with your hand in neutral. Elbow extension. Your main one is going to be that triceps back on the back. Your Anconis also does, but it doesn't really do extension. It's really not a factor in force production with elbow extension. It's mainly just that triceps. And remember, the triceps is a two-joint muscle with the long head of the triceps, so it's going to depend, that force production is going to depend on what position the shoulder is in. Okay? Supination, provided by the supinator, biceps brachii, and your brachioradialis. Why not your brachialis? Because it doesn't attach to what muscle? Well, not what muscle, what bone? The radius. Remember, if a muscle is going to provide supination or pronation, it must insert onto the radius. Okay? Pronation, pronator teres, pronator quadratus down at the distal radial ulnar joint. Okay? Wrist flexion, we're going to cover this now, but we're going to talk about the wrist later on. Wrist flexion on the medial epicondyle is going to be that common flexor tendon, right there, common flexor tendon for your flexor carpi radialis, flexor carpi ulnaris, your palmaris longus, and then your flexor digitorum superficialis. Okay, remember, especially the superficialis and profundus. Okay, those are going to affect or have an effect on every joint that they cross, right? So when the fingers cross, if there's no active kind of co-contraction from the wrist extensors, they're going to force that wrist into flexion. Okay? We talked about that yesterday in 120 lab. All right, so with wrist extension, you're going to have your extensor carpi radialis longus and brevis, your extensor carpi ulnaris, and your extensor digitorum. It's very helpful that this is all wrist extension, and they are named for that. Wrist flexion, the ones that majorly do that are going to be your flexor carpi ulnaris, flexor carpi radialis, and your flexor digitorum. Again, very, very helpful that our muscles are usually named for what they do. All right, so referred pain and nerve injuries. Remember when we talked in 120, we ran across dermatomes. Okay, so multiple dermatomes cross the elbow, but none are isolated to just that region. Okay, so there's not even a peripheral joint or nerve map that is just located in that region. Okay? So you really, if you have any numbness, you kind of have to isolate it down to what area it is. Nerve disorders. The ulnar nerve travels in the cubital tunnel on the posterior medial aspect, and that is a common place for compression. When we talked about the elbow in 120, if you rest your elbows on something hard, if your patient has a computer that they're working on a table all the time and they're resting their elbows on a firm surface, truck drivers will occasionally get this. because they rest their elbows on their elbow rest. You can have trauma to that area where you bang it into it, and you can have nerve entrapment and nerve injuries there. Okay? So it's important to also remember, like we talked about in 120 lab, kind of what those nerve issues are going to be. Okay, so if it's an ulnar nerve, right, you're going to lose the ulnar side wrist flexion, wrist extension. You're also going to lose your adductor pollicis brevis, or your adductor pollicis, because remember that ulnar nerve comes in, swoops across, and picks up that adductor pollicis. Okay, radial nerve tracks under the origin of the extensor carpi radialis brevis, and then it breaks into superficial and deep branches. And that median nerve crosses the elbow joint in the cubital fossa. Okay, and entrapment may occur between the heads of the pronator. So either it's going to go underneath the pronator, or it can actually split the pronator depending on kind of what your genetic makeup is, and it can be entrapped in either of those areas. Okay, that median nerve gets everything else on the ulnar side, right? And then also your thenar eminence, hypothenar eminence, not hypothenar, thenar eminence, and then your lumbricals. Okay? So you're going to see wasting away in that area. You're also going to get that sensory distribution lacking in the distal fingers. All right. Again, if we have issues, the lecture material that provided in 120 covers a lot of this. If not, write it down. We'll cover it in lab. Okay. So now we're moving into kind of those acute stages. Okay, and then this is your book kind of isolates them into the different types of pathology. So the first one it talks about is the joint hypomobility, non-operational. So this is your rheumatoid arthritis, your juvenile rheumatoid arthritis, your degenerative joint disease, which I've talked to you guys, I'm sure, about my dislike for that term, or any acute trauma leading to any immobilization. Okay, this can even be a proximal humerus fracture that they're now in a sling. Okay, and now that elbow is now isolated or immobilized, and now it's going to be tight. It's going to be swelling, all that stuff. Okay, so in the acute stages, you're going to see swelling, muscle guarding, and pain that restricts elbow flexion. We don't really want to stretch through that pain, so we want to kind of do our grade 1s, grade 2s, kind of get rid of some of that swelling, do our soft tissue techniques, exercise and stretch in kind of the pain-free areas. With subacute and chronic, you're going to get a firm end feel with the presence of a capsular pattern. So with the elbow, the capsular pattern flexion is more restricted than extension. And then you can lead into restricted pronation and supination. Okay. So with what's our techniques, what's our approach to joint hypomobility? We're going to, first phase is going to protect. So educate for pain control, EDL modifications, reduce the effects of mobilizations with small motions within the pain-free range, grade 1 or 2 mobilizations. Soft tissue and joint mobility, that's going to be our main focus. Okay? And then maintain the integrity and function of related areas. So keeping the scapular stabilizer strong, wrist and hand strengthening. So not really just focusing on the elbow, right? But more focusing on the joints above and below, because we don't want those to degrade as well. Okay, so phase 1 is just like the protect phase. Get swelling under control, get pain under control, small motions, and maintain the areas around it. Sorry, I didn't mean to hit my ring on the table. Okay. Then we move into phase 2. Phase 2 is called the controlled motion, and this is where we increase soft tissue and joint mobility with the grade 3 and 4 mobilizations. We can do manual and more aggressive self-stretching, and then improve joint tracking utilizing mobilization with movement. We don't really go into that too much. There's a couple of our clinicians that are out in the field that people really enjoy having as clinicians because they do utilize mobilizations with movement. And then improve muscle performance. So this is where we really make our bread, right? This is where we start getting those load resistance exercises. We're going to start usually, and you're going to talk about this tomorrow in lab, when we talk about the shoulder, but we're going to start in the open chain, and then as we progress, we're going to move into more closed chain exercises. And in phase 3 is always a return to function. So normally, with everything that we're going to talk about, there's 3 phases. The first one is just getting things under control, getting pain, swelling under control, protecting other areas. Phase 2, getting into the strengthening, getting things up and running. And then phase 3 is going to return to function, whether that's your line worker at Bosch who's doing the same thing every day, to your guy who's working on the flight line down at Cherry Point who's working above head, or their nurse, or their adolescent athlete who has to get back to the athletics. Okay, so just trying to recreate those things as much as we can and working on those individual muscles. Okay? And we're going to talk about this tomorrow. Not tomorrow, during lab. Okay. Then we're going to move into joint surgery and post-operation. Okay, so open reduction with internal fixation. Those are going to be when we have plates and screws and everything put in and to stabilize areas. So those are dislocations, radial head fractures that you'll see that with. Sometimes they'll take the radial head excision out. So they'll take the radial head excision where they take the radial head out due to damage and replace with a prosthetic. I have personally never seen this done. However, your book says it is possible, so I will believe it. Okay, so phase 1, if you wanted to, you could over here, you could put phase 1, okay, and then phase 2 here. But early phase, maximal protection phase, again, you'll see protection phase. If we go up 2 slides, you're going to see protect phase there as well. Okay, so we're going to maintain mobility, sounds familiar, maintain elbow and forearm mobility, and then minimize muscle atrophy. Moderate and minimal phase, we're going to increase range of motion, improve functional strength, and return to normal. So I know these are all very broad terms and broad descriptions, but as we get into it during lab, you'll kind of see kind of the basic strategies that we use. Okay, for our total shoulder, that's a replacement of the distal humerus and proximal ulna. It can be linked and unlinked. It used to be in the early days they were like directly attached. I don't believe that is accurate too much anymore. I don't think that it looks like that. I think it's more kind of free gliding. Again, this is not common. You do not see a lot of these at this moment in time. I'm sure that as we progress medically, we'll see more. Okay, so we want to minimize the time for full mobilization. Okay, just like kind of when we went with how we progressed with total knees. If you've ever seen someone total knees used to be in the hospital for 4 days. Okay, and then they were in a immobilization brace for another 3 weeks. Right, that's not how it is anymore. Right, now you get one. If you're doing well, you get 1 hospital night stay after your anesthesia, and most people will go home the next day walking with minimal use of a walker. Right? So we've gotten to the point medically where we know that immobilization is bad and that we want to minimize that. Okay, so early phase, maximum protection phase, maintain mobility of adjacent joints, shoulder, wrist, regain motion at the elbow. This is going to have a protocol. And minimize atrophy, so we're going to use isometrics and muscle setting to be able to turn those muscles on and get the body used to firing those muscles. Okay? Moderate and maximum protection phase, continue with increasing range of motion of elbow. We can be a little bit more aggressive with our stretching techniques during our moderate and maximum protection phase, and and then we can regain full functional strength. Okay? So contraindications, high load progressive exercises with our elbow replacements, heavy lifting, and recreation activities that place high loads to the elbow. So golf, throwing, racket sports traditionally are going to be kind of disallowed throughout the rest of their life. I'm sure that as these things progress, they'll get more and more refined and they'll get better and better. Okay, you used to not be able to play golf after you had a hip replacement. Now, as things have progressed, as long as that joint is stable, most orthopedic surgeons don't really care. Okay. Myositis ossificans, that's a bone formation. That's a little calcification there. in the muscle and tendons as a result of trauma. So extension more restricted than flexion, because as you can see, as you try and extend, there's going to be soft tissue that grinds in that, which is the opposite of rheumatoid arthritis. Okay? Surgical excision with rest and gradual return to activities. High load is not going to be good. So this is going to be a slow procedure, slow progression. Okay? Grade 3 and 4s, not good for myositis and ossificans because you don't want to re-stimulate that calcification of tissues. Okay? Lateral tendinopathy or tennis elbow. These are all overuse syndromes. Okay, so anytime you see a tendinopathy, it usually means an overuse injury. Okay, so medial elbow tendinopathy or golfer's elbow, okay, also known as medial epicondylitis. These are just irritations of those common tendons. Okay, so anytime you see a tendinopathy, and if you're looking for something to do your research project on, management of tendinopathies would be awesome. Okay, because there's lots of studies that are out there that, especially showing lots of good positive signs for eccentric strengthening. Okay, just trying to increase that load exponentially and getting those tissues to regenerate. Okay, Wolff's Law. So management, early protection phase, decrease pain, you don't say. Develop soft tissue and joint mobility, obviously, and then maintain other upper extremity function, right? So these are all things that we've seen before that we can utilize, okay? Or that we've seen together, that we've been talking about, really. Okay. Management, control motion, return to functional phase. So we lumped phase 2 and phase 3 into this. So we're going to increase muscle flexibility and scar mobility. We can do the manual stretching with PNF, our self-stretching or cross-fiber massage. We can restore joint tracking with the radial ulnar joint, and then improve muscle performance and function. So counterforce strap, dynamic strength training, including eccentric. So highlight, circle, star, anything you want to do with eccentric training. The studies, and I would really love for someone to do their research study on this. Looking at the effects of eccentric training on tendinopathies. That would be awesome. Okay. Then plyometric resistance training. Remember, with plyometric, we have to reduce the amount of time that a task takes. Okay, and education on prevention. Okay. If you've ever seen anybody walking around with those bands around with a little pillow, with a little air sac pillow, okay, usually they have an overuse syndrome. And what that does is it creates a secondary attachment point for those muscles, and it's going to decrease the amount of strain on the origin. Okay? We can talk about that more during lab as well. And with the wrist and hand, moving into the wrist and hand, so our distal wrist articulates between the radius, ulna, and the proximal row of carpals. Okay? Remember, the ulna doesn't articulate with the proximal row. It has that fibrocartilaginous disc. It mainly articulates with the radius. We have 5 metacarpals, 14 phalanges, and why not 15? Why? Because the thumb has 2, not 3. Okay, make up the hand and fingers. Radiocarpal joint is the distal radius is concave, and the carpals are convex. So during wrist flexion and extension, you have a convex moving on a concave. Roll and glide are opposites. Okay, the carpal joints are uniplanar, and in 2, 3, and 4, however, the 5th is biaxial. Palm of the hand is supported by the transverse and longitudinal ligaments, and then during flexion, the arch is increased, allowing a cupping formation, which allows for improved grasp. Right. So if you take your hand and you go into wrist flexion, it deepens that cavity or deepens that arch to allows you to kind of grasp, especially round objects, easier and better. Okay? During extension, the palm of the hand is flattened, which allows for better release. Okay? So if we could think of flexion as a grasp and extension as release, that deepening and shallowing of that arch helps with that whole process. Okay? The thumb, brief structure and function still. So thumb carpometacarpal is a saddle shaped. We talked about that in 120 lab. Our MCPs are biaxial with collateral ligaments on either side for stability, which are taut in flexion. We talked about this in lecture in 120, I believe, right? So our MCPs, if they're tight in flexion, you can't go side to side. However, if you go side to side in extension, you can get some wiggle going on, okay? And PIPs and DIPs are uniaxial with collaterals on either side, which are tight in extension instead of flexion, right? So if I bend my digit, I can get a lot of side to side. If I extend it, I'm not going anywhere. It locks it in. Okay, so there's difference in open and closed change positions. Just outlining kind of the bones of the hand. We don't need to go over that. So the function, there's an intricate balance between extrinsic and intrinsic muscles of the hand and wrist. Remember that our extrinsic muscles kind of do the power, and our intrinsic muscles kind of do the fine motor movements. Okay. The position of the wrist controls the length of the extrinsic muscles of the digits. We talked about that in the lab in 120, right? So if we go into full flexion, okay, those wrist extensor muscles, our extensor digitorum, are going to be lengthened. Therefore, they're going to be passive insufficient. Okay, whereas if we go into full flexion, wrist flexion, our flexor muscles are going to be shortened maximally, and they're going to be actively insufficient. So they're going to be weak in that position. Okay. We also talked about the role of your wrist extensors during grasp. Okay, so they must contract and stabilize so that you don't go into over wrist flexion and mess up with that length tension relationship. Okay. Talked about that again. If you have questions, write them down, and we'll go over those questions as needed. Okay. We know what the extensor hood is. That's a structure on the dorsum of the fingers made up of the extensor digitorum tendon, the dorsal and volar interossei, and the lumbricals. In an isolated contraction of the extensor digitorum, it produces MCP hyperextension and IP flexion. Okay. PIP and DIP extension occurs as a result of our interossei or lumbrical activation and their pull on the extensor hood. Okay, so if you look at our extensor hood, our lumbricals, okay, are going to be right there. As those contract, they're going to stiffen that extensor hood when our MCP is in flexion. Okay, hope that makes sense. Okay. So we talked about power grips. We talked about precision grips. Okay, so our power grips are going to be your cylindrical, spherical hook. Okay, those are going to require our extrinsic finger strength. Okay, our precision patterns are going to be our pad to pad, tip to tip, and pad to side. Okay, those are used for manipulating objects that are not in contact with the palm. Pardon me. Alright, so management of wrist and hand disorders, just like with the elbow, starting with hypomobility. We have our rheumatoid arthritis and degenerative joint diseases. So with RA, you're going to have acute stages, and you're going to see a lot of RA in the hands. That's usually kind of the tall tale area that we look at with RA. Okay, so in acute stages, you're going to have pain, swelling, warmth, and limited motion. And it's a progressive muscular weakness and imbalances between intrinsic and extrinsic. Okay. Once we get to the advanced stages, we can go back to our acute stages. So you're going to have swelling and warmth. That's kind of how you know someone's in a quote-unquote flare-up, is that those MCPs especially are going to be hot, swollen, and just really red. Okay. The advanced stages, you start having capsular weakening, cartilage destruction, bone erosion, tendon rupture, and muscle weakening leading to subluxation deformities. And that's that deformity. That's called your ulnar drift. And you'll see that a lot. Many of you probably have elderly grandmothers or sometimes grandfathers, mostly elderly grandmothers or elderly women who have what's called that ulnar drift, where those proximal phalanges just drift to the ulnar side. Okay, and it can get pretty abrupt. It can get, that's pretty. I mean, look, that's like 45 degrees, right? That's 90 degrees. That's at 0. That's right at 45. That's a lot. It's a lot of ulnar drift. Okay. So with degenerative joint disease, you get degeneration of articular cartilage. So those early stage, you have early achiness and stiffness, which progresses to swelling, warmth, and restricted motion. And then same thing with advanced stage, you have capsular laxity, resulting in hypermobility. Okay, and instability with progression comes contractures and limited motion. Okay? Again, I hate the word disease in this. It just makes it sound like it's something that's curable, and it's not supposed to happen. All of us are going to get degeneration. There's only so much tread on tire. Anyways, hate it. Okay, so post-immobilization hypomobility, decreased range of motion with firm end feel, tendon adhesions, decreased muscle performance. So in those early phases, okay, we're going to control pain and project other joints, right? Education, NSAIDs, 1 and 2 MOBs, splinting, activity modification. Again, just trying to get things under control, stop the progression, and kind of start on that road towards recovery. We're going to maintain joint and tendon mobility as well as muscle integrity with passive range of motion, active assisted range of motion, or active range of motion or active assisted. Tendon gliding, we're going to do that, okay, during lab, and then multi-angle isometrics just to get those muscles firing. Okay, and in the phases 2 and 3, we're going to increase joint play, increase our mobilizations. Okay, we're going to improve strength, mobility, and function, just like with anything else that we've already talked about with the shoulder and with the elbow. Okay, just trying to get them back to normal. Okay. Joint surgery and post-operative management. We have arthroplasties at the wrist, MCP, IP, and CMC of the thumb. The CMC of the thumb, we've actually seen a couple of those are getting more and more popular. I have some, if you move your thumb around and you can kind of feel some grinding in there, you'll probably need a replacement of your CMC. I probably will in my left hand at some point. In general, the maximum protection phase, we're going to maintain and later improve mobility of unoperated joints. Okay, restore control mobility. Going to use those tendon glidings. You could just say grade 1 and grade 2, not grade 2 and grade 2 mobilizations. Regain use of wrist, finger, and thumb musculature, and then pain control. We've seen that already. Okay, again, minimum protection phase and return to function. Gradually ramp up the strength. Gradually ramp up into, and instead of just doing isolated open chain strengthening, progress it into grip strengthening. Progress it into what they need to be doing. Maybe they like to sew. Maybe they like to swing a hammer. Whatever they do or whatever their goals to get back to, that's what we want to start transitioning them into. Okay, so traumatic lesions, surgical and post-operative management with flexions. Okay, so if you look in box 1910 and 1911, okay, in your Kisner and Colby book, okay, these are gonna kind of be where those are, especially in flexion, and then I believe that's a extension, flexion, extensor, yes. Okay. So depending on the depth of the lesion, it can affect one or more tendons. Okay, this is accompanied by vascular, nerve, and skeletal injuries. Can be a direct repair or a tendon graft. Poor outcomes associated with delayed repair. So especially if you get into the tendons and they have to reconnect the tendon, you don't want it to be like 12 hours old. You want them to be there as soon as possible. Okay? So post-op management, in general, every effort is made to prevent adhesions, preventing proper tendon gliding. So when we do our hands or our wrist lab, we'll go over tendon gliding, and you'll be able to kind of feel what that's like. Okay, the earlier the therapeutic intervention, the better. It just especially if it's a tendon repair, if it's a direct repair, we have to be very, very cautious because tendons and ligaments don't heal very well, right? Because they're avascular, they're aneural, they don't have a blood supply. Okay, so their healing time is going to be very slow. Okay? The other big thing, especially in the hand and wrist, is going to be scar prevention. With there being it's not the same skin that you have on your forearm. I can lift my skin on my forearm. I'm not too worried if I get a laceration about scar tissue. Here, everything kind of connects to that fascia underneath. Okay, so what I don't want is for that scar tissue to kind of take effect and really limit the amount of gliding that my tendons have. Okay, so approaches: early controlled motion, delayed motion. It's based on the quality of tendon repair, and it's going to be up to the orthopedic surgeon or the hand surgeon. Most current day emphasize early controlled, protect active and passive exercises. Okay, that box 1914 and 1913 outline those rationales. Okay, so maximum protection phase, first 3 days to 5 weeks. Okay, again, max protection phase 1. We're going to be working on pain, edema control, and protection of the new repair. We're going to do that by utilizing a dorsal cock-up splint. Okay, having that splint on the back is going to prevent those tendons, those flexion tendons, right? We're talking about a repair of our flexors from going into extension, right? It's going to keep that wrist here, keep your fingers there, so that way you can't go into that position and really stress or stretch those newly repaired tendons. Okay? Individual motions of the PIP and DIP, and then minimum tension with short arc motions. We do not want to overly stress those new tendon repairs because they are fragile and they take a long time to heal. Okay? Moderate protection phase, 4 to 8 weeks. Emphasize on safely increasing stresses on repaired tendons to eventually return to full flexion and extension range of motion. Okay? Active range of motion, tendon gliding and blocking. We can kind of get a little bit more aggressive. And in the minimal protection, we can get super recovery or super aggressive, return them to function, return them to their daily life, and really start harping on the strength and really stress those newly repaired ligaments. Okay. Your extensors, okay, they're also separated into zones. There's more zones on the extensors because there's more tunnels. Okay. Injuries to zones 2 or 3 and 7 pose the greatest surgical and rehab challenges. Okay. Those improvements in repair techniques have allowed for earlier mobilizations. So general guidelines again, main goal is to decrease adhesions and return to function. The extensor ligaments don't pass through a common pathway like the flexors do, but through a different areas of pulleys that are across the dorsum of the wrist. Okay? Each one of those tendons, like your extensor digitorum, each one of those has a different, what's it called? Like a bursa. No. A synovial glide. A synovial pass that they glide through. Okay? And that's kind of why there's more zones, because there's more pulleys. There's not one carpal tunnel like your flexors have. Okay? The static volar splint to decrease amount of available flexion. Okay? Patient is taught isometric early to decrease amount of stress to repair site. And then the composite flexion of the MCP, DIP, or PIP and DIP is withheld for at least 4 weeks. Again, you don't want, if we repaired one of these tendons, you don't want them to do that. Okay? That's a maximal stress of those tendons, and they could rupture those tendons again, and your orthopedic surgeon would not be happy with what you are doing. Okay? So on the flexor side, right, this is usually what, if you have a good orthopedic surgeon, I've seen surgeons not do this, and they end up getting trigger finger or something like that. What a good surgeon will do, they'll do kind of a zigzag cut, so that like an accordion. Okay, if you think of like an accordion file or an accordion, okay, that zigzag allows that whatever that is to stretch and minimize. You have to remember that scar tissue is not regular tissue. It's going to be firmer. It's not going to be as elastic. Okay, so you have to have some excess built in, like this orthopedic surgeon has done, in order to maintain that tissue extensibility once that scar's down. Okay, this is going to be a volar splint, so as opposed to that splint that prevents finger and wrist extension, this splint is going to resist wrist and finger flexion. Okay, so this guy probably had a repair up underneath here of, I'm guessing, that tendon of the extensor digitorum, because that one is the one that is held with an outrigger. That's called an outrigger, and that is, it's just held up so that he can't flex that MCP at all. They usually don't wear this for too long. If you go to Carolina Orthopedics for one of your clinicals, Brian's our hand therapist there, and he does a fair number of these, so it's pretty cool to observe those. All right, so that's all we have for elbow, wrist, and hand. We're going to go over a lot of this stuff in lab. If you have any questions, please write them down, and we will talk about them in lab. That is all I have for you now. I will see y'all in lab. Have a good day. Peace.